Good afternoon, everyone. I'm Christy Koenig, the EMS Medical Director for the County of San Diego. Thank you so much for joining us for the next lecture in our series of evidence-based medicine presentations. Today, we're pleased to welcome back one of our favorite speakers, Dr. Veer Vithalani, who is prepared to talk for us entitled Capnography, Not Just for the Intubated. I love that title. Dr. Vithalani serves as the Base Hospital Medical Director for Palomar Health here in San Diego. He was formerly the Chief Medical Officer for the MedStar Mobile Healthcare System in Fort Worth, Texas. With extensive expertise in EMS resuscitation, quality improvement, and data analytics, he's well qualified to speak to the use of capnography in the management of our pre-hospital patients. We look forward to learning the best science on this important topic. Thank you so much, and over to you, Veer.
Thanks, Dr. Koenig, and thanks everyone for having me. Let me go ahead and share my screen here. You guys hear me okay?
Perfect.
Perfect. Awesome. All right. So yeah, as was mentioned, I'm going to be talking a lot about capnography today. And I think, most of us are used to the traditional uses in terms of intubation confirmation, but we're going to talk a little bit about other airway modalities and some other sort of non-airway techniques where capnography can be used. So I do not have any conflicts of interest to disclose. And there is one slide with some trade items and whatnot, but I'll again disclose it there. So as I mentioned, we're going to cover a little bit about the background of capnography, as well as just sort of a recap of respiratory physiology and how it plays into capnography. We'll talk about end-tidal CO2, its measurements, and how that's performed. We'll also spend a lot of time on clinical uses. And it says end-tidal CO2 quiz, but I forgot to take that part out. There won't be a quiz today, so no worries. So, really when we get down to capnography, capnography is really is one piece of your sort of B in your ABCs of breathing assessment. And really the B in ABCs is really broken out into really oxygenation and ventilation, right? So you have your two techniques or two sort of items that you use to assess your breathing. Pulse oximetry measures that oxygenation. And really when you're using a pulse oximeter, you have to understand that there's a lag time associated with that, not just in terms of the machine itself, which if you've ever gone into your monitor and messed with the averaging time, most of them are set at around 12 to 15 seconds. So it measures and it's really looking back at the sats for the last 12 to 15 seconds. You can actually update that in really critical patients if you want, if you've got a good waveform. But also when it comes to things like passive oxygenation and really how a patient's breathing, there's overall a lag in a patient's ability to sort of accurately represent their oxygenation status. And there are times where it's inaccurate. So traditionally, we've talked about carbon monoxide poisoning. That's obvious. People with very poor circulation or who are hypotensive, where you may not be getting the best plus waveform on your monitor. Those times it can really be inaccurate. And from a measurement standpoint, understand that pulse oximetry and oxygenation really is determined almost entirely by two main items. One is your fraction of inspired oxygen, so your FiO2, and then one is your PEEP, or your positive end expiratory pressure, and we'll sort of cover a little bit about that later. But when it comes to measuring ventilation, that's where capnography comes in. So ventilation is really a much more immediate assessment. So especially if you're using waveform capnography, which is really what we're talking about when we say capnography. It's really an immediate measure of apnea, of hypoventilation. It's accurate in pretty much all circumstances, as long as you are getting air to the expired air to the device itself. And understand as well as part of that, ventilation and sort of capnography is really determined by your respiratory rate as well as your tidal volume. And actually those two, combined, the product of which is minute ventilation. That's really what we're talking about when we say ventilation. So how do we measure end-tidal CO2? So I'm pretty sure we've all seen these, purple, yellow colorimetric detectors on the right. They are technically qualitative, even though they have sort of a color gradient there on the outside where you're supposed to be able to judge, how much CO2 there is based on how much of a shade of purple or brown or yellow the color is coming on. But essentially, it's really positive or negative. If you actually really go back, technically, you're supposed to give 6 full breaths through the device in order to accurately say whether it's reading or not. That's due to any sort of gastric insufflation of carbon dioxide, etc. And they're single use. When I go and teach residents and things like that, I always ask them the question, where's the best place to put this? And in my opinion, it's really right here in the trash can, especially if you have quantitative and tidal CO2. So when we talk about waveform capnography, we're really talking about two pieces. There's the numerical value, that's the end tidal point, and then there's the actual waveform itself, not just from an individual waveform by waveform perspective, but there's also the trend of the waveform over time, not only in its value, but also in its shape, which is something we'll talk a little bit more about here. And so when you want to measure a quantitative or waveform capnography, I think we've all seen the traditional sort of nasal cannula ones. There's also the ones that you can attach to the standard connector on an endotracheal tube or supraglottic airway. I think other ways that we sort of forget about is when it comes to bag valve mask ventilation, there are approved effective ways to measure end tidal CO2. So this is the end tidal CO2 sandwich, we call it, where you place it between your bag valve and your mask. You can also place a nasal cannula underneath the mask itself. And if you're performing a good mask seal, you will be able to measure end tidal CO2 accurately using that device as well. So just a quick recap on sort of respiratory physiology. So your respirations are almost entirely sort of made up by the drive to blow off carbon dioxide. I know there's still sort of the big question mark in terms of hypoxic drive for certain COPD patients, but pretty much most patients we're talking about have a drive to blow off carbon dioxide, and that's why we breathe. There are 3 steps to ventilation. So obviously you have to move air between the atmosphere and your lungs. You have to be able to move carbon dioxide and oxygen across the cell membrane in your pulmonary capillaries and across your alveoli. And then your cells themselves have to be able to consume oxygen and produce carbon dioxide. And so that's going from a very high to low level. You actually have to perform all of those steps in order to actually have ventilation. And so when we talk about what is it that we're actually measuring when we're looking at end tidal CO2, specifically for waveform capnography, essentially in your detector, you have a beam of light, an infrared light that's being shot out across the sample of gas that exists within your detector. That is bouncing off of all of the different molecules of the air, so oxygen, nitrogen, carbon dioxide. Carbon dioxide absorbs a wavelength within the infrared spectrum, and then the light that emerges out the backside is captured by the detector, and essentially what you're looking at is a partial pressure. It's essentially a ratio of how many molecules of carbon dioxide there were versus how many anything else there was, just generic air, and that is what is then reflected on your waveform. And so the sort of traditional 4-phase waveform that we're used to seeing has several pieces. So your phase 1 or your baseline is sort of what is your dead space ventilation. So that should be 0. It's not always for a lot of reasons, but it should be 0. You have your ascending phase or your exhalatory upstroke, where you are beginning to exhale. You have your alveolar plateau, where your pressure of atmospheric pressure and your sort of pulmonary pressures are the same. And this is where that main expiration is occurring. You have your end tidal point, which is what we're used to talking about. It's the very end of that plateau. And then you have your inspiratory downstroke, where as you breathe the air back across the detector, you're pulling in fresh air that shouldn't have any carbon dioxide, and it comes across the detector and rapidly drops that down. And so depending on how nerdy you want to get with me, you can look at the different angles, the alpha and beta angle, you can look at everything. But I think the most important part to note about the waveform is that the shape changes depending on a lot of circumstances, and the measurement that you're getting is right there in that top right corner. It's essentially the last number right before the inspiratory downstroke. So when we talk about end tidal CO2 values, I think there's this concept of a normal value being 35 to 45. I really don't think that specific range is as important as trends across the patient, but there are certain circumstances where those numbers, sort of numerical values, do come into play. There's a lot of things that can increase your end tidal CO2, and so like we talked about originally, probably the most common ones are decreased minute ventilation. So that is a low respiratory rate or a shallow tidal volume. And again, that's not necessarily a singular shallow tidal volume, but really a prolonged period of low tidal volume causing a decrease in your minute ventilation. Increased cardiac output. Cardiac output is actually sort of has a corollary with your carbon dioxide. And again, that has to do with that blood flow moving through and the oxygenation and the cells being able to produce more CO2. Obviously, if you give sodium bicarbonate, which then converts into water and carbon dioxide on a cellular level, I see this a lot in patients with cardiac arrest who receive sodium bicarbonate, late in the arrest for, unknown reasons, in my opinion. You'll see a sudden bump in their end-tidal CO2. That's not necessarily an increase in your cardiac output, but that's really just the body metabolizing the sodium bicarbonate. Effective bronchodilation, if you have somebody who is able to now blow off the CO2. And then there's a handful of other reasons, but really the big ones are the ones in the left column there. And similarly, end-tidal CO2 is decreased by the exact opposite. So increased minute ventilation, so high respiratory rate or larger tidal volumes, decreased cardiac output, especially a patient who is peri-arrest and then goes into cardiac arrest. This is another way you can sort of identify that as a sudden drop in their end-tidal CO2. Pulmonary embolism, which again comes back into the blood needing to be able to have that gas exchange at the capillary level in your lungs. And there's some caveats there with pulmonary embolism, but it does drop your end-tidal CO2. And then again, other reasons as demonstrated. And so again, I sort of mentioned that to me, it's a lot more about your overall trend of your CO2 that helps you understand what's happening with that patient. So somebody who is becoming, more obtunded and has a smaller respiratory rate or smaller tidal volume can have an increasing CO2 over time. One of the ways you can sort of identify this is, I'm a big believer that monitor alarms are meant to be customized per patient. So if you have take a narcotic overdose, for example, who's received no naloxone and you are not sure if they might need it in the future, speaking more to the emergency department really, but also in the pre-hospital space, you can set your end-tidal alarm at 5 millimeters of mercury above their baseline. And that way you'll know if their respiratory rate is insufficient and you might need to dose them, etc. Similarly, downtrending due to increased respiratory rate over time, increased tidal volume over time, etc. We talk a lot about certain waveforms, but this is probably the most prominent. So it's really the obstructed waveform, and oftentimes referred to as a shark fin appearance. It primarily points to bronchospasm. So you start getting a widening of that alpha angle and sort of a curvature of your end-tidal CO2. As you get, as this begins, your end-tidal actually rises and your curve increases. But as the obstruction becomes severe, if you have extreme severe bronchospasm near respiratory insufficiency, you'll get a drop in your end-tidal because you're not actually able to expire much air at all, and that plateau isn't occurring. And so again, just an example of sort of that shark fin type appearance. So why does this waveform really exist? Well, if you think about in your 4-phase waveform, if you have all your alveoli that are able to inspire and exhale at equal rate with each other, and there's sort of no issues with your inhalation, then you get that waveform. But if you have a heavy predominance of bronchospasm down at those lower levels, not only does it take a longer time for you to reach that alveolar plateau, but there's also more carbon dioxide, and so it takes a lot longer. So that trapped carbon dioxide takes a lot longer to release, and thus you see that slow sort of rise to the top. So, let's talk about some clinical uses. So I see some, I didn't realize there was a chat here. Pull that up. All right. So let's talk about some clinical uses. So I always like to start with a bit of a real life example. It's probably one you've at least heard of or seen before. So let's talk about a crew that's dispatched to an overdose who is conscious and breathing, 43-year-old female, dispatched about 9:50 p.m. This is a BLS first response crew. They show up and note a decreased level of consciousness with a GCS of 6, shallow respiratory rate, high heart rate, and unable to measure blood pressure. They initiate high flow oxygen. And there's a question there as to whether the patient is diabetic or not. So the blood sugar is noted to be elevated. And ALS crew arrives on scene. They note that the patient's unresponsive completely. They document her as a GCS of 3. They initiate BVM in the ambulance after moving her there, are unsuccessful in their intubation the first time. The second time it's successful, but their end-tidal CO detector is clogged due to presumed vomitus, and it is replaced. That second one is also clogged. And during transport, the patient becomes bradycardic, progresses to PEA, and then an asystolic arrest. If you were at my last lecture, you will know that I am a very, 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 very big believer in the objective review of cardiac monitor files, really for any case, not just cardiac arrest. And so you will note here that similarly to the documentation, there is a sinus tachycardia. End-tidal CO2 is not attached, but when it is attached to the endotracheal tube, it shows a flatline waveform and was documented as clogged. It was removed and replaced. Similarly, you had an end-tidal CO2 of 0 with worsening hypoxia, and ultimately the classic signs of severe hypoxia, which is bradycardia, widening of your QRS, and eventual cardiac arrest. All the while, the end-tidal CO2 detector deemed clogged, but the airway deemed successful by the EMS crew, and eventually that patient expired. And so I think that's probably one of the most common types of cases that brought up the rationale for using end-tidal CO2. And so I think it goes, it's an important piece to start with in terms of the clinical uses. So probably one of the most talked about uses of end-tidal CO2 is to verify your endotracheal tubes. It's not just for verifying placement, but also to ensure that you have adequate ventilation. Especially in your really critically ill patients, it is often difficult to rely on your clinical signs. And similarly, especially in the pre-hospital environment where you may be moving from the field to the ambulance to the hospital, sometimes adding in helicopters or other units in there, it is a very quick and easy way to monitor the position of your ET tube during transport and help prevent unrecognized, misplaced, or dislodged intubations. If any of you have heard of the Do It for Drew project or other similar projects, a lot of this circles around this area of minimizing sort of malpositioning during transport. I think it's important to note that waveform capnography is the gold standard for a lot of reasons, and as much as you have probably heard the adage of trust the patient and not the monitor, I think there are certain circumstances where that will get you into trouble. And so, for example, this was a study done in Europe by pre-hospital physicians that were performing advanced airway management. They were subsequently, there were folks asked to sort of auscultate the lungs and the epigastrium to try and determine whether they felt that the endotracheal tube was in place. If you're familiar with sensitivity and specificity, sensitivity is your rate at which you can rule out a disease, so ruling out a misplaced airway, and your specificity is ruling in a disease or ruling in a correctly placed airway. So there was, not quite perfect agreement there of auscultation of the lungs and epigastrium. Capnometry, the physical detector, the colorimetric detector, was able to be 100% sensitive, but not quite specific. And capnography waveforms, once again, showing when used appropriately, can reach up to 100% sensitivity and specificity. I would not be foolish enough to ever say that 100% is actually the right answer, but this is what these folks published in their paper, and I think it at least reaches up to 100% sensitivity and specificity. So again, when you're talking about a flatline waveform, really that is apnea or a dislodged airway. If you are assuming that your detector is clogged, if you have a solid line, then by definition, you are getting gas. Going back to the very beginning of the lecture where we talked about how that measure is performed, if gas is reaching the detector, it is drawing a solid line. If it is not reaching the detector, it essentially times out and draws a dashed line. And so it's important to note that whichever device you're using, or if the patient is breathing on their own, a flat line is always a bad sign, and is something needs to be done about it. It should not be left alone. As mentioned before, esophageal intubation, similarly to how you need 6 breaths through a colorimetric detector to correctly identify a tube. You can get carbon dioxide out of the stomach if they have recently drunk a carbonated beverage, or if they have other reasons for having CO2 in their stomach. You typically will not get a 4-phase waveform because it will not follow the same flow as your ventilation, your effective pulmonary ventilation. Stomach insufflation oftentimes will give you this molehill or sort of hill-shaped waveform, and very quickly it sort of makes its way down to zero. You can get something, but this is why colorimetric detectors can be inaccurate compared to waveform capnography, because you sort of have that. And I think it's important to note that this is not a new concept. This is actually a study back from when printed text looked like this, of pigs that were intubated and had their waveform capnography measured. You see here on the top that there was initially tracheal intubation. They then moved the endotracheal tube into the esophagus and measured the carbon dioxide, which gives you that flat line or those very small molehills. The tube was removed and then intubation reoccurred. Subsequently, it was moved to the retropharynx, which I think is, again, an important concept that we'll talk about here in a minute. And then again, they were reintubated and showed a good waveform. And so the retropharyngeal space, essentially, if you are performing intubation, but don't get it all the way through the vocal cords and the tube is lodged in the retropharynx, you may get some ventilation in there, but it is not typically a good four-phase waveform. It's usually something that falls its way back down to esophageal intubation, because essentially the pressures to get it into the esophagus is a little lower, and the air tends to go in the wrong direction. This was a great study done by some friends out in Florida that looked at fresh frozen cadavers. And so one of the things when I had first done my first paper and QI article on unrecognized failed airways, was there was this overarching belief that, you know, if I arrive too late to a cardiac arrest and this patient is too far gone, that the reason my end tidal CO2 was zero is not that I had misplaced the airway, but that the patient was too dead. And so this was actually a study done that took fresh frozen cadavers that had been dead for really several days. And this was part of a paramedic initial education lab. So there were paramedic students that were performing endotracheal intubation, and they essentially did it with video laryngoscopy, confirmed every intubation, and then measured the end tidal CO2. And as you see here, from time zero on the x-axis, ranging all the way down to 6 hours or so, whereas the volume does drop as you are ventilating a cadaver, you do end up with successful end tidal CO2 ventilation for several hours after ventilation is initiated. And you see there across the top, they purposefully performed some esophageal intubations as well as some hypopharyngeal intubations. And again, they were unable to get any carbon dioxide out of those intubations, as opposed to the successful tracheal intubation. And so there's not, in my opinion, a rationale to believe that a flat line of zero is due to somebody being too expired. This was a second cadaver that was used in the same study and showed very similar results, although it did not last quite as long for them. They reached the threshold of 5 at about the hour mark, which again, I doubt we are working on the resuscitation that long with an unrecognized airway. So, and then lastly, to that end, just again, a dashed line end tidal CO2 is representative of no air getting to your detector. A flat line means something and should be actioned upon. And in my opinion, this is really everyone's responsibility to be aware on the scene of a cardiac arrest. If there is a flatline end tidal, you should be willing to call out your colleagues and ask what's going to be done about this, because this is, in my opinion, sort of a cardinal sin for EMS. Inadequate end tidal endotracheal tube seals. Again, you know, you need that effective air exchange. So just another way of showing you that sometimes you get a good waveform and things start to fall off. That could be a tube that's deflating. It can be a tube that's dislodging, etc. And so, as you're aware, I have my high horse about this topic. This is some work I had done in the past. I think it's important that if you as an agency are performing advanced airway management in any realm, I think it's really important to have a quality improvement program around your airway management. And that should include both prospective and retrospective review of your airway placements. It's really not just endotracheal tubes, and I'll talk about the rest in the future. But I'm a big fan of airing dirty laundry and showing improvement. This was my old system right there at 20% back in 2015. This was predominantly supraglottic airways, but we had a big problem of unrecognized failed airways. And it took us, several years of concerted effort. But to assume that you don't have the problem without the data to back it up is really a fool's errand, in my opinion. And so implementing waveform capnography, implementing those monitor file uploads, as was mentioned earlier, and making sure that you are retrospectively reviewing your care. I always liken it to watching the tape of a professional or really even high school sports team, right? There's not a team out there that doesn't go back and watch their tapes to try and improve. We're no different in EMS and healthcare. This is something that should be built into all of our programs. And I'm happy to elaborate on this further, but it's not quite the point of the lecture. So again, as I mentioned, it's not just for the intubated. So really, in my opinion, waveform capnography as a measure of ventilation is really just as important as pulse oximetry for your patients who are unwell. And so whether you have a patient who is spontaneously breathing, whether you are performing bag valve mask ventilation, or you are performing, if they are on CPAP, like a flow limiting CPAP, or if they have an endotracheal tube or supraglottic airway, really all of these should have ventilation confirmation. And again, I stress a lot about bag valve mask ventilation. BVM is very much touted as this sort of quote unquote basic skill. But truly, it is one of the more complex airway techniques that we have. Not only do you have to have a patient with a patent airway, you have to ensure a good mask seal. You have to ensure that your ventilation technique is appropriate, that you're not insufflating at too fast or too much, like too quick a speed or too much volume. You should be ensuring the oxygenation side, not just the ventilation side, by using a PEEP valve for really most patients. And similarly to my last slide, in my previous work, I had found that it's not uncommon to have the belief that you are adequately ventilating a patient, but when retrospectively reviewing capnography waveforms, that you are actually not ventilating the patient. And in my system, it was 8.5% or so. That was an unrecognized failure of BVM. And so this is, again, a reason that we can't just assume that we're doing a good job. We have to prove it both real time and retrospectively. And so how do we really focus on BVM? So obviously positioning for patency with your ear stool notch, plastic in every hole above the neck. So, NPAs and OPAs, getting a good mask seal. I'm a big believer in the sort of two-person technique and the thinner grip as opposed to the EC clamp. And then, opening the airway sometimes is very difficult. Sometimes you need 3+ people to get a good mask seal in order to ensure adequate ventilation. And then when it comes down to it, you have a lot of tools to make sure that you are adequately oxygenating and ventilating your patient. Capnography is really just one of those tools. So, the PEEP valve, I understand, is a relatively sort of recent local implementation for PEEP valves. Understanding again that even if you're performing bag valve mask ventilation with 100% FiO2 or as close to 100% as you can get, another good way to increase your oxygenation is by implementing a PEEP valve. And so you see an example there in the bottom left that you can, it's essentially a dial, a flow kind of technique where you can set the PEEP itself, and you'll definitely feel a difference in your ventilations. If you are needing to increase it further using a flow-controlled CPAP, or even now a flow-controlled bilevel ventilation device, measuring your tidal volume and your inflation rate. So there's a lot of ways you can do that. One is through muscle memory, which is how we've traditionally tried to do it. But like a lot of things, it is hard to be perfect at everything. And so there are devices out there. So Zoll, with some of their monitors, have come out with a sort of attachment that you see there in the middle in blue that sort of measures your tidal volume and your insufflation rate. There are timer lights, as you see next to the monitor there, where it tells you how often to ventilate. There's a company called Safe BVM where they actually have a device that you place that actually stops you from ventilating too quickly. If you try and ventilate too quickly or too much, it will forcibly slow you down. Again, I have no conflicts with any of these companies, but I've really met most of them. And honestly, we shouldn't be afraid to implement tools that are going to improve our overall oxygenation and ventilation. And lastly, as I mentioned on my high horse before, NAMSP, if you're familiar, did put out a position statement on a lot of airway techniques. But really, I leave this here for you to read it later on the printout. But you should have an airway management QI program. Capnography is really one piece of that. Oh, I have a conflict here. I wrote this and led the task force for this. But really, you should have a quality management program for airway management, whether it's even if it's just bag valve mask ventilation. You should be focusing on this. And again, I'm happy to help anyone who's interested in starting or improving their program. Moving on from ventilation, we can talk about sort of other uses for waveform capnography. So cardiac arrest, I think, is the sort of second thing that comes to mind when we talk about end-tidal CO2. Cardiac arrest is really your sort of peri-arrest or low perfusion states. So during a cardiac arrest, obviously, end-tidal CO2 definitely correlates to your cardiac output. As we talked about before, you need all the pieces to that, and that middle piece of ventilation is blood circulating through your pulmonary capillaries in order to exchange oxygen and carbon dioxide. And so it's not only a measure of cardiac output, but it's thus a measure of how good your compressions are. Because the better your chest compressions, the better your cardiac output, thus the better your end-tidal CO2. And as probably has been talked about by others several times, it is one of the earliest signs of return to spontaneous circulation, a sudden rise in your end-tidal CO2. And so it's also a very good prognosticator when it comes to cardiac arrest. And so there's good data out there that says roughly at the 20-minute mark, which is the sort of where a lot of the data sort of cuts a line in terms of being able to perform prognostication or not. An end-tidal less than 10 at the 20-minute mark basically has a 0% chance of survival. I think it's like 0.1% or something along those lines. But at 20-minute, if your end-tidal is less than 10, you basically have an unsurvivable case. Anything greater than 20 has a higher but not great chance of ROSC. This is where there's a bit of a gray zone, but that's why there's a sort of 20-minute marker there. And then, as I mentioned before, any sudden increase of greater than 10 millimeters of mercury is oftentimes a sign of ROSC. This is not due to, as I mentioned before, sodium bicarbonate administration or any other rationale. So, for example, when you go from a tired compressor to a fresh compressor, if you're doing manual compressions, you may often see a rise in your end-tidal CO2. This is a sort of intra-arrest rise in your end-tidal. Non-intubated patients. So again, even if you have someone who is in respiratory distress, or if they are obtunded or unconscious, we'll talk a little bit about metabolic acidosis. End-tidal CO2 is really a really nice, easy way of assessing your ABCs, because if you have a waveform, that means you have a patent airway. If you have a waveform, it's representative of your respiratory pattern. You can see whether you can see what the rate is, you can see if there is bronchospasm, you can see if it is shallow, etc. And then a normal-ish end-tidal shows that you have adequate perfusion, and thus, if you place a nasal cannula end-tidal detector on a patient in respiratory distress, you will pretty much immediately complete your ABCs, at least to a certain extent. And again, the beauty of that is there's not as much motion artifact as compared to pulse oximetry. It is reliable in low perfusion states. And so it is a nice, easy tool that really should be incorporated into a lot of your sicker patients, not necessarily just breathing patients in respiratory distress. Seizures are another good example. So there are really a handful of things you'll see in a patient who's actively seizing. If you see no waveform and no chest wall movement, obviously they are apneic. Remember that whereas some patients with a seizure, a heavy majority of them, especially during and after their seizure, go apneic. It's something that should be quickly and sort of rapidly identified. And so this is an easy way to do that. If they have a low waveform and a low end-tidal CO2, they may look like they are breathing, but actually be ineffectively ventilating. And this is one of those gray zones where I think we can make a really big difference, because you're going to get a lag in your SpO2. And by the time you identify that they are hypoxic, you could have already noted that they were ineffectively ventilating and been performing some bag valve mask ventilation to improve their ventilatory effort. And then conversely, if you have somebody with a normal waveform and a normal end-tidal CO2, then you know that they're effectively ventilating, and you can focus on other tasks and simply allow yourself to monitor that. This is, let's see, let me check if I can quickly share the audio here too. sound. So through context cues, you can probably guess what kind of situation this is. But there's a great example here of one of the things that end-tidal CO2 is probably one of the best at identifying. So you see here, I have had countless colleagues in really all walks of healthcare tell me that this patient is effectively breathing. That's what they're telling me. Oh, I'll say we need to ventilate this patient, and they'll say, oh, but they're breathing. See, their belly is moving, their chest is moving. But if you note, everything is sort of happening in the wrong direction, right? He's trying to inspire, his chest is contracting, his belly is rising. And I used to teach a lot of emergency medicine residents and whatnot. The first couple times you see this, your brain sort of knows something is wrong, but it takes you a little while to understand what exactly is happening. And so, again, this is somebody with an upper airway obstruction from a lot of different reasons. That patient had obviously obstructive sleep apnea. That was him getting a sleep study. But if we were measuring his end-tidal CO2, we would note that he would suddenly have no waveform. And despite his chest wall moving, there would be no breath sounds. And these patients are typically responsive to airway alignment maneuvers. And so this comes up a lot in patients who are undergoing procedural sedation, if they've gotten high doses of opiates, or in cases where truthfully they occlude their own airway just due to positioning on the cot. This is an easy way while you are focused on other tasks to notice that this is happening. And that's probably one of the biggest reasons that all monitoring devices is useful, is it's monitoring the patient for you and can alert you when things happen. This is a sort of common occurrence that I see, and simple airway alignment maneuvers can improve this. But there is also a very similar disease of laryngospasm, which basically looks exactly the same. You have no waveform, you have chest walls that are moving, you have no breath sounds, but they are unresponsive to airway alignment maneuvers. And for laryngospasm, you need to provide positive pressure ventilation. Now, laryngospasm isn't that common, but there is one medication that is in a lot of our arsenal that can cause laryngospasm in a certain percentage of administrations, and that's actually ketamine. So ketamine is a great drug. I will sing its praises all up and down. But like everything, you need to know about the good and the bad of all medications. And laryngospasm is a known adverse effect of ketamine administration, even at lower doses, like for pain relief. And so it's something to be aware of when you are administering ketamine for analgesia. As I mentioned before, really any other patient that you think may have a hypoventilation state, so procedural sedation, if you're giving pain management, I am a big believer that if you have a patient who is intoxicated on opiates, there's no rationale in slamming high doses of opiate reversal agents and causing acute withdrawal. You can monitor them effectively with your tools, especially end-tidal CO2. And as I mentioned before, I think it's a great technique to simply adjust your monitor parameters so that it alerts you, so that you are aware if the patient is ventilating adequately or not. Metabolic acidosis is another interesting one. This is a graphical representation from a study that looked at end-tidal CO2 across the x-axis and sodium bicarbonate levels across the y-axis. And as you can see, there's a pretty decent corollary here that the higher your bicarbonate, getting closer to normal, you have a normal end-tidal CO2. And as you come lower and lower on your sodium bicarbonate, your end-tidal CO2 does sort of reflect that. This is actually takes a second to wrap your brain around this graph because it's technically three-dimensional, but this was a subset of patients with diabetes, both with and without DKA, and sodium bicarbonates of 15 or greater on the left and less than 15 on the right. And what you see is these zeros, ones, twos, and threes represent how low their sodium bicarbonate level is, and then the y-axis represents their end-tidal CO2. And so again, in patients without DKA who had essentially normal or high normal sodium bicarbonate levels, they had above that 30 of carbon dioxide. But in patients with DKA, even though there was some inaccuracy towards the top, you had a handful of patients with very low sodium bicarbonate levels that had a low end-tidal CO2. And conceptually, this makes sense. Going back to the same rationale as when you administer sodium bicarbonate, you increase someone's CO2 This is all part of the Henderson-Hasselbalch equation, where if your body is trying to buffer out acidosis, you end up dropping your CO2 by turning it into sodium bicarbonate inside your body. Similar to causes of metabolic acidosis, sepsis actually has some good data for end-tidal CO2 measurement. So this was the same folks as the cadaver study, actually, Chris Hunter and the late Sal Silvestri, who looked at patients with greater than 2 SIRS criteria and an end-tidal CO2 less than 25 with a suspected source of infection. They used this as a sort of a flag for whether or not these patients were sort of a sepsis alert or not. Again, without getting too nerdy, there's a statistical concept called the area under the receiving operating curve that's on the right. The main thing you need to know is that how much gray is underneath your line. The closer it gets to 1, the better your test is. And so as you see here, 50-50, which is this purple line, is worthless, but a nice tall line there, which really gets like 90% or so, is excellent. And so the area under the ROC curve for sepsis, for that criteria I mentioned, 2 SIRS criteria, a suspected source of infection, and an end-tidal CO2 of less than or equal to 25, had a 99 on the area of the ROC curve, with a pretty wide confidence interval there for sepsis in general, which makes sense because 2 SIRS criteria plus a suspected source of infection is sepsis. But similarly for severe sepsis and for mortality from sepsis, it actually had an 80 and 70 area under the ROC curve, which is actually pretty good compared to a lot of other things. I know people have studied pre-hospital lactate measurements and things in the past for sepsis, but this is a non-invasive, easy tool that you can implement for a patient that you are suspecting severe sepsis. If you have an end-tidal of 20 and they are coming from a nursing home and they have a presumed UTI and they're tachycardic and tachypnic, then you know right there that they likely have severe sepsis, and you can get the ball rolling early. Again, for severe sepsis, the sensitivity and specificity was also pretty good, essentially meaning that from a sensitivity perspective, if those criteria were not there, you can rule out severe sepsis pretty well, but you might miss some if you solely rely on those criteria. And then, as I mentioned before, in the same realm of sepsis, serum bicarbonate, end-tidal CO2 definitely correlates with your serum bicarbonate levels. It actually correlates with your anion gap, whether it's DKA or lactic acidosis or anything else. And then it correlates with your lactate as well. And all of these are backed up as part of those papers, that these are sort of corollaries for your end-tidal CO2. So with that, actually, is pretty much it. I'm, as I mentioned before, big believer in end-tidal CO2. It's awesome. Use it for everything. That's my opinion. Operations, I used to have a good time with my operational colleagues. I know the cost is there. I know that really everything is sort of a joke, but especially if you're performing any sort of advanced airway maneuver, any sort of basic airway maneuver, any respiratory or really critically ill patient, I think it's a very useful tool to implement. Gives you a lot more data than sort of we are traditionally used to. And last but not least, because this comes up a lot, don't get fooled by airway obstructions. Your end-tidal CO2 is a great way to objectively measure whether or not someone is breathing, even if it looks like they are. So ran a little short, but happy to answer any questions and touch on anything else. I saw a question in the chat pop up. What's a physiologic explanation for the cadaver, which is ventilated, no CPR, producing CO2? Yeah, it's an interesting one. My understanding is that, if you really think about it, even though your body is dead, you still have cells. Those cells still may have the necessary byproducts to create CO2. And similarly, there's probably some carbon dioxide left within all those, pulmonary tissue. That's my understanding. I don't think it was... they weren't like providing it with CO2 or anything else to try and get it. The cadaver was fresh, but it was a couple days old. Yeah, it wasn't. It had gone to a university ME's office and then had been donated and then was fresh.
Just for people listening who can't see the chat, the question was the cadaver freshly dead? So very interesting study. Thank you for the fabulous lecture. I was really interested too in the last part where you were talking about pre-hospital sepsis detection, because I've been seeing in our own system that the provider impressions for sepsis have been out of range recently for actually days on end. So having this tool, I think, is going to be very helpful. And in fact, we're going to be having a whole EBM lecture on sepsis next calendar year. So that is an area I think we can follow a lot more. Let me ask if anybody has any questions, feel free to put them in the chat or raise your hand. Such a comprehensive lecture. I'm not sure if we'll have any more questions, but let's give people a couple minutes. Wow. Seeing some compliments, but no questions. Yeah, I agree. I think this is an absolutely fabulous tool that we can use in all settings, in the pre-hospital setting as well as the emergency department, and gives us a lot of really good information. Anybody else have any questions or comments?
Hey, Christy, Dave Duncan.
Go ahead.
Hey, Veer, great lecture. Really, really amazing. Appreciate it. Since you have some time still hanging, could you make some comments for us on dead space? And what I'm really thinking is, in pediatrics and neonatal, we run into issues with adding additional devices, end-tidal sensors. And I'm thinking about the Emma device by Masimo. We end up adding some dead space, and it contributes to the CO2 and the ventilation, even oxygenation. I haven't really been tracking the data on like Emma for neonates or peds. Have you seen anything, or can you make commentary as to how concerned we should be about additional dead space?
No, I think that's a great point. I think as you rightly pointed out, really the smaller you are, the smaller your expected tidal volume, the more of an impact that has, right? Like somebody who's ventilating me, the extra 10 mLs or whatnot isn't going to make as much of a difference. But a neonate, I completely agree. I think all those things really just have to be taken into consideration. I think it's when you think about the detectors themselves, there is a long tube. There's a misconception sometimes that tube is not filled with carbon dioxide, right? The detection is happening within the actual space of the gas sampling, and so there is some additional ventilation space that needs to happen there. But by mentioning dead space, you brought up something that I had sort of seen a lot of before. But again, this is where there are plenty of patients where you show up and they look like they are ventilating, but if you put them on end-tidal CO2, you would get these molehills, and they really are screaming and telling you that they are just moving their dead space. I've seen tons of patients like this where when they are peri-arrest and you are not really focused on that portion enough to notice it, this is a way to sort of raise your flag trigger. And I have a bunch of cases, monitor files I could show that says these patients need bag valve mask ventilation early to help prevent their cardiac arrest. And when we fail to do so, a lot of those patients decompensate. But remember that dead space, even in any patient, you have to overcome that dead space to perform any ventilation. And so similarly to what you're mentioning when it comes to ventilating pediatric patients, even for adults, they have to be able to have the respiratory effort to overcome their own dead space. And patients who are peri-arrest oftentimes don't have that. And even if they're moving their chest up and down, they may not be overcoming their dead space. And the way for you to measure that is with waveform capnography.
Yeah, I think those are really good points. It's really interesting when you're running a cardiac arrest, when you're running a code, to watch the end tidal, because it's more sensitive than pulses. Like if somebody's about to lose pulses, a little bit before that, their end tidal is going to drop. And vice versa, when they're about to regain pulses, a little bit before that, their end tidal will rise. So pay attention to that next time you're running a code. It's quite interesting. Any other comments?
Thank you, Veer. Appreciate it.
Okay, I'm just seeing a lot of kudos in the chat. Thank you so much. And again, this lecture is recorded, so feel free to listen to it afterwards. And we'll go ahead and break. Thank you very much.
Thank you all.